Can I start? All right. Well, I'm sorry everything is so delayed, but I'm not really worried because I know that in Spain you eat your supper very, very late, so I'm not that bothered about it. Well, I'm delighted to have this subject to talk about. It's one I've been interested in many years, and it's interesting that in the last 2 years only, there have been some marvelous publications which didn't exist before. So deciding what's going to happen and how to handle a person who's undergoing surgery with cirrhosis, it's about prediction. And we know that prediction is very difficult. Niels Bohr told us that it's very difficult, especially about the future. Whereas Lao Tzu, who was the father of Taoism in China, says that those who have knowledge do not predict, and those who predict do not have knowledge. And I think that's very true of politics. Of course, Shakespeare knew everything, and if you look into the seeds of time and say which grain will grow and which will not, then speak to me. But not all predictions are good ones. You know, heavier than air flying machines are impossible, Lord Kelvin said. In the middle of just before the stock market crash in 1929, Irving Fisher thought that things were doing very well in the States. I'm just wondering about now. And the bottom one, Walter Lippmann, said among the really difficult problems of the world, the Arab-Israeli conflict is one of the simplest and most manageable. Now, 70 years later, we may just see the beginning of something. So the surgeon comes to you and says, my patient has cirrhosis, should I operate? And one hopes they ask you beforehand rather than in the middle of the surgery. So here is a case that was given to me, 84-year-old woman with NASH cirrhosis who'd had a HCC resected a couple of years ago, also cholecystectomy. She now presents with bloody stools and a fungating mass is seen, the hepatic flexure. She's got ascites, requires diuretics, monthly paracentesis. She lives in a nursing home, has mild dementia, but not encephalopathy. Now, the key results of her investigations, low platelets, low sodium, low albumin, and you calculate the Child-Turcotte-Pugh class is B, a score of 7, but funnily enough, the MELD is only 11. But if we use the Mayo post-operative surgical risk score, which I will explain a little later, you see it predicts a mortality of 33% at 1 month and 48% at 3 months. And so the question is, surgeon says, should I operate? And maybe we should put a TIPS in. What do you think? And this is from Narayan and Men gave me this case a little while ago. So let's look and see how we can evaluate it. Now, here is a slide showing 7 of the recent excellent reviews of this topic. There you see my one is back in 2018 and a whole lot of new ones. Now, I'm not expecting you to write these down because if you would like copies of any of these articles or indeed a copy of this lecture, please just contact me. There you see my email address. Now, most of the studies that we use to make our decisions are actually retrospective. There's a lot of selection bias and quite inconsistent criteria, except in the last couple of years, we have some actually very good, this one prospective study and so on, and this one here. So things are getting better. Now, my purpose in giving this talk is to establish in patients with liver disease, first of all, that surgery is really risky and not just a whim of the surgeon who doesn't want to operate. And why is this the case? What methods do we have for assessing disease severity and the comorbidities? I'll review some selected operations, common ones, and then come up with a simple decision tree, if you like, for management. But the whole thing is about prediction. It's what we expect will happen under certain circumstances. Now, here is an enormous study published now nearly 11 years ago from an inpatient database, and you see that in cirrhotics, 22,000 of them, the hazard ratio was anywhere from 3 to 8, compared with many million of non-cirrhotics. And if we looked at those that had portal hypertension, which is a smaller number, there you see that the hazard ratio is anywhere from 12 to 23. So I think this is good evidence that it's dangerous. Now, here are 6 studies in Denmark. They're able to collect data on almost everybody in their country. And you see that there are 6 studies here of very common operations, prostatectomy, nephrectomy. If we look just at the odds ratio of mortality at 30 days, it's anywhere from 3 to 11 times more dangerous in cirrhotics than in non-cirrhotics. So I think the point is very well made with these fairly hard data. Now, the reasons why surgery is risky are many. I don't expect you to read this table, but if you look at the review that I published 2 years ago, which I'll gladly share with you, you can see there are at least 10 reasons. And most recently, in this review from Newman and colleagues published just this year, you can see that the changes in the liver in terms of metabolism, portal hypertension, etc., give rise to changes in hematologic parameters, renal electrolyte, immunology, and so on. And that gives rise to a range of surgical complications. So one of the ones that I really find most interesting was published by the APSL now 6 years ago, and it was a review of the outcome of what they called acute insults in patients with chronic liver insults in terms of acute on chronic liver failure. And so cirrhosis considered a chronic insult, surgery is an acute insult, and the prediction then was that this could give rise to acute on chronic liver failure, but there actually were not too many data at that time. Now, just this year, Klein and colleagues have shown the results of a prospective study of the development of acute on chronic liver failure after surgical interventions. And this is just one of the graphs showing that patients who went into surgery without ACLF to begin with, in fact, their mortality was much worse who developed ACLF than those who did not. So this is one of the insults that occurs in surgery is an acute insult. The second question I want to bring up, and one that I think is being dispelled, what I call the myths of the INR. And this was an article of faith amongst interventionists and surgeons who insisted that we transfuse plasma into our patients with an elevated PT INR, otherwise they would not do the procedure. And the idea was that patients with elevated PT-INR have excessive bleeding with invasive procedures, that frozen plasma will correct the PT-INR, and therefore giving this will prevent or minimize procedural bleeding. And this is all nonsense. All of these assumptions are false. Now, it's not to say that an elevated PT-INR doesn't predict about a bad outcome of surgery. Remember, it reflects hepatic function. It's a component of both the Child-Turcotte-Pugh and the MELD scores. It does predict a poor outcome from surgery, but if you look extensively through surgical literature, you will see this not due to bleeding, but due to infection or other deterioration of liver function. In fact, rather than bleeding being a risk, thrombosis is actually more likely, and we're learning now that thrombosis, deep venous thrombosis, portal vein thrombosis are more common in patients with cirrhosis than in non. Now, the big question then is, when was the cirrhosis known about? Was it known already? Was it suspected? Was it discovered? If it was known preoperatively, then obviously the severity and the risks of surgery can be calculated before you even start. If it's suspected, then we have to investigate, confirm or refute the diagnosis. And this is rather a nice clinical paper in JAMA a few years ago, which looks at the reliability of history-taking examination and simple laboratory tests, which I find still very, very useful to be a bedside physician. On the other hand, if you discover that there's cirrhosis present, then obviously you must postpone the operation, assess the severity electively and the risk of surgery, and depending upon the urgency of the case, think again. Now, sometimes the surgeon asks you, calls you from the operating room and says, I found cirrhosis, what do I do? You don't ask the question, did you miss it? Did you ignore it? Or did you not appreciate the importance of the findings before you started? But all they can do is rapidly assess the risk of continuing, and assuming they have minimal data available to calculate the Child-Pugh and the MELD scores, and they should have a prothrombin time INR. They should know if the patient is confused. They should know if there's ascites. They should know if the patient has elevated bilirubin, and therefore they could make an informed judgment during the surgery whether to continue or to abort the operation. Here's a rather remarkable cases reported nearly 40 years ago from King's College Hospital in London, a formidable medical center where 36 patients underwent laparotomy who were not suspected of having liver disease at all by the surgeons. If you look through the cases, it's obvious these patients had liver disease and should never have gone to surgery. The results were outstanding: 61% morbidity and anywhere from 30 to 100% mortality, especially in those with viral or alcoholic hepatitis. And so it's important to remember that these type of cases still do occur even these days. Now, what sort of assessment should you do? Allegedly, if the person is normal, and I put that in italics, there's no need to check anything. But how many people do we really think, how many patients we think are really normal? So we must always take a very good history: alcohol, high-risk behavior, which means maybe hepatitis C infection, metabolic syndrome, family history of liver disease, and actually look at the patient for signs and symptoms of not only liver disease, but cardiopulmonary disease, simple tests such as pulse oximetry. What are the laboratory things that we should look for? I'm only giving a few examples. Mild macrocytosis is often overlooked as a marker of liver disease. A mild prolongation of prothrombin time. The viral hepatitis is so common and so silent that we should always test it. And if the blood gases saturation oximetry is less than 96%, then blood gases need to be done. If you have a suspicion, we need to get some sort of abdominal imaging, cardiac echo, because pulmonary hypertension, not uncommon in cirrhosis. We rarely need a liver biopsy, but if you have the suspicion there's cirrhosis or alcoholic hepatitis, it's worth doing. As you'll see later on in the talk, more and more we are recommending measuring hepatic venous pressure gradient before hepatic resection, certainly, and now other surgery as well. Now, I don't have time to explain all of these tests here. They're all known to you: Child-Pugh score, the end-stage liver disease MELD score, the anesthetic score. Breath tests are becoming reintroduced, the methacillin breath test and so on, not yet a routine. Indocyanine green clearance, very popular in the Far East and with some surgeons, but that's really about it. Now, quite simple tests can give you a clue that there may be cirrhosis present. Here is a study published by Todd Stravitz in Richmond, Virginia, a number of years ago, of some patients who had presented with hepatocellular carcinoma, but were not suspected of having liver disease. And you can see quite simple measurements: the platelet count, the AST-ALT ratio. If these were present, any one of them would give you a 30 to 50% chance the patient has cirrhosis. But if any of these were present, the probability goes up to around about 80%. So these somewhat trivial blood tests really can be quite useful. Now, what about the results in patients with liver disease? I've already mentioned that acute hepatitis can be quite fatal, especially alcoholic. And even in recovery, a patient recovering from alcoholic hepatitis is still a severe surgical risk. There are no data yet on drug-induced autoimmune disease. Chronic hepatitis really depends on the severity of the hepatic injury. Hemochromatosis does not pose a liver problem so much as dysrhythmias, heart failure, diabetes, infection. And in Wilson disease, surgery can aggravate the neuropsychiatric symptoms, and penicillamine, if it's being used, impairs wound healing. Now, non-alcoholic fatty liver disease, so common, hepatic resection in these patients is 2 to 5 times more fatal than in patients who do not have fat. Hepatic decompensation in patients with fatty liver disease is much worse if it's steatohepatitis rather than just pure steatosis. And additional risk factors are the diabetes, the obesity, and other aspects of the metabolic syndrome. The mortality rate in bariatric surgery, if the patient has decompensated cirrhosis, is an odds ratio of 21-fold. Compensated cirrhosis, still twice as fatal compared to controls. And cirrhosis may be completely unsuspected to the tune of about 6%, and this poses a mortality risk of about 5-fold. And so bariatric surgery obviously should be avoided in patients who do have portal hypertension. And once again, we might consider doing hepatic venous pressure gradient measurement. Now, what about abdominal surgery? Here's an old study from 1984, and it's a phenomenon I want to introduce to you, that according to the Child-Turcotte-Pugh grade, there is a stepwise increase in mortality. You say, well, this is a very old study. This is nearly 40 years old. But if you look 13 years later, the same type of study was repeated in a mixture of alcoholic and non-alcoholic cirrhosis, and you can see that the stepwise increase in mortality goes up as a Child-Turcotte-Pugh criteria increase. Abdominal surgery, overall mortality, taking all those factors into account, is around about 16 to 28%, twice that if it's an emergency compared to elective surgery. Now, here are 5 studies over a span of 20 years with number of cases ranging from 24 to 100. And I have indicated the worst mortality in a stepwise fashion from child A to B to C, and you can see 17%, 32% up to 100%. In the last study, they looked at the MELD score, which they divided into 3 percentages, and you can see that there's the same stepwise increase in mortality. A study published a few years later by Beffler and colleagues decided that a MELD score of greater than 14 was far more predictive of bad outcome than a Child-Turcotte-Pugh grade of C. Now, the Mayo Clinic, over a 25-year period in 2 batches, looked at the mortality of all forms of operation, independent, whether it was abdominal, orthopedic, ENT, and you can see when the MELD score was above around about 10, that's when the operative mortality went up dramatically. The mortality at 1 year, of course, doesn't reflect the surgery, it reflects the severity of the liver disease. And here you can see relative mortality risks in intra-abdominal operations or total operations that Pat Northup reported a couple of years earlier from Charlottesville. So not all studies actually agreed with my idea that there's a stepwise increase in mortality with child score. For example, here's a very good study 10 years ago from Mount Sinai, which shows, yes, morbidity goes up in a stepwise fashion with Child-Turcotte-Pugh class, but mortality does not. But we have to look a little closer at the center and at the patients, because 3/4 of these patients were herniorrhaphy and cholecystectomy, 40% were done laparoscopically, and it's a very highly specialized liver surgery and liver transplant unit. One thing was interesting, though, those with a MELD score above 15, which was about 1/3 of the patients, If they had a low serum albumin, the mortality was terrible. But if the serum albumin was better than 2.5, which is really not that great, but nonetheless, then the mortality was only 14%. So I think we have to look at the results in terms of the nature of the surgery, but more important, who are the surgeons who are performing it. Now, I've mentioned a number of times already hepatic venous pressure gradient. Here is the early study from Jordi Bruges in Barcelona, showing that if the HVPG was less than 10, and here actually of the 18, 14 were less than 10, then the outcomes were good. Whereas if the HVPG was consistently above 10, then the patients with hepatic resection for carcinoma tended to deteriorate. This study was in a sense repeated a few years later, and this time in addition to the HVPG, which could be less than 10 or greater than 10, they added the additional question of what the bilirubin level was. And you can see from these Kaplan-Meier survival curves that HVPG above 10 with an elevated bilirubin gives you the worst prognosis. Now, to this year, actually, this study has been repeated much more extensively. And on the left, you can see the mortality over time according to the HVPG, whether it's above 16 or below 16. And here you can see over time the mortality if the HVPG is above 16. And so now a new cutoff for the HVPG should be somewhere between 10 and 16. How much liver can you remove? Well, a normal liver, you can leave the patient with 25% unless they have a peak bilirubin level above 7 or 119 micromolar. But if it's a cirrhotic liver, obviously you cannot leave as little as that. And people have developed some guidelines at 5 days as to what the outcome will be. If the INR is greater than 1.7, the bilirubin is greater than 50 micromolar, then you have an opportunity of a mortality of 59%. This is the mortality risk score from the Mayo Clinic. On the left-hand side, you see the variables that they measure, and on the right-hand side, you fill in the blanks. And if you do that, you can see it gives you a mortality likelihood a week, 1 month, which is operative mortality, and then 3 months, 1 year, and 5 years, which again, as I said earlier, reflects more the level of the liver disease rather than the surgery. But again, this is a useful guideline. Now, what about patients with cirrhosis who undergo cardiac surgery? Here you can see a survival study from Mayo Clinic where child Turcotte A at 24 months, 20% mortality, B is 55%, and C all the way up to 84%. And overall, from a number of other studies, it's anywhere between up to 11% for A, up to 50% for B, and up to 100% for C. And morbidity is occurrent in all CTP classes, and you see the levels of morbidity these patients suffer. And the risk factors in patients with heart disease are whether they have an elevated central venous pressure, how much time is on cardiopulmonary bypass, do they have non-pulsatile bypass, do they need pressor support. Cholecystectomy previously was considered a formidable operation in excess of 25% mortality, worse for alcoholics and non-alcoholics, and an 11-fold risk of death. But if you look at these 7 studies, it's rather small, but you look at these 7 studies and a whole range of patients who underwent laparoscopic cholecystectomy, most of them were child Turcotte A and B, you can see that there was some morbidity, but actually only 2 patients of 7 patients in the whole group died. So with the CTP of A or B, a MELD score of less than 18, fewer complications, shorter anesthetic and surgical times, reduced blood loss, shorter hospital stay, and few, if any, deaths. And recommendation can be made that if it is so urgent, either a subtotal cholecystectomy can be done or even a cholecystostomy to allow the patient to improve until definitive surgery can be done. A few years ago, Perkins and colleagues revisited open cholecystectomy, this time using the MELD score. Unfortunately, very few patients in this study, but you can see if the MELD was less than 8, there was no risk of deaths. MELD higher than 8, 2 of the group, which is only 6%, died. So MELD can still be useful to deciding about open cholecystectomy. Now, as far as biliary tract disease is concerned, it's been known since 1983 what the risk factors for laparotomy in patients with obstructive jaundice. Those that were anemic, had jaundice, and a malignant cause of the obstruction, if all three were present, mortality was 60%. If none of them were present, was only 5%. There was a vogue for preoperative drainage. It seemed logical, but the prospective studies were promising. But when prospective studies were done, the whole thing is abandoned. For external drainage via percutaneous cholangiography, too many complications, no benefit. Internal drainage via ERCP, again, not shown to improve survival. There are a couple of exceptions. If the patient has acute cholangitis or intractable pruritus and surgery is delayed, then it's worth doing preoperative drainage. And in hepatic resection, some surgeons believe that resolution of jaundice may actually improve regeneration in the remaining liver after the surgery. Here are a few other operations. Esophagectomy sounds quite formidable, only 16 patients, but you can see the same stepwise increase in mortality for esophagectomy. And it's a funny thing to say, but it actually cures the patient's varices in a funny way. Orthopedic operations, there are not many good reports. This one, morbidity and mortality combined, but you again can see the stepwise increase in bad outcomes according to the Child-Turcotte-Pugh score. Now, a lot of surgeons ask, shall I put a TIPS in to reduce the risk of abdominal surgery? And here are 4 studies. You don't have to go through them in detail. There's only one that actually compared patients to case controls. And although Daniel Azulay's study suggested it was beneficial, the other 2, not so sure. And this comparative study for case control study shows no suggestion of a benefit, although surgeons will say that the bleeding is less when they have TIPS present, but whether we can actually show a benefit of the TIPS is really uncertain at the moment. Now, what about umbilical hernia repairs? What's happened here? This is rather faded, I'm afraid, but there are one large retrospective series in which cirrhotics did poorly compared to non-cirrhotics. That's umbilical hernia. Whereas on the other hand, 3 small retrospective series, despite that they were mainly Child-Turcotte-Pugh B and C, actually only showed 4.8% mortality. And you can see in these particular studies, 2, 3, 1 deaths only. And so it's unclear about the risk of otherwise of repairing umbilical hernias. I think what we can say is the patient must be optimized, the ascites must be controlled, and it's best done electively before the patient presents with incarceration, acute obstruction. Oh, sorry, this is the first very large study of something like 1,200 cirrhotics versus 30,000 non-cirrhotics, when the results for the cirrhotics were really very poor. So in assessing the postoperative mortality in patients with cirrhosis, there's this very nice new study just published, I think it's in this month, in Clinical Gastroenterology and Hepatology, where they go through the risk factors from the disease, the risk factors associated with surgery, and other things such as comorbidities and demographics. Now, the wish is to have models that will evaluate the input of all of these variables. Unfortunately, those models don't exist, but in time, it's going to depend on the factors that I show you down below, which are involved in the preoperative decision. One small question, and that is for the anesthetist and in the ICU, what drugs do we use? We use fentanyl and sufentanil, not morphine. We use atracurium for paralysis. Propofol, very, very good for sedation, even in patients with acute liver failure. Short-acting diazepams because of their extra hepatic glucuronidation. avoid long-acting benzodiazepines, and these are the anesthetics that have minimal hepatic metabolism. So in summary, surgical mortality in cirrhosis correlates with the MELD scores and the Child-Pugh scores, and they rise stepwise with the Child-Pugh class, but the optimal MELD seems to vary with the type of surgery, unlike the Child-Pugh. And surgery is contraindicated in acute hepatitis, especially alcoholic, and in patients with CTPC, MELDs above 10 to 15, or an HVPG above 10 to 16. Additional risk factors for mortality, age, ASA score, low serum albumin, and so on. Portal hypertension is a major risk factor for morbidity, especially in patients undergoing biliary or cardiovascular surgery. And in patients with obstructive jaundice, surgical outcome is not generally improved by preoperative decompression unless it's to help the patient's symptom of pruritus or cholangitis. So here is a rather simple decision tree for the preoperative evaluation of patients with liver disease, depending whether it's acute hepatitis, fulminant hepatic failure, known cirrhosis or no cirrhosis, and you can see what the decisions you should make depending upon these measurements. Now, one thing is interesting, and that is you should look for varices and ascites, and if none are present, I think in this day and age, we should measure HVPG if we're considering big operations on patients with cirrhosis. So back to the patient that I presented earlier, 84-year-old woman with NASH cirrhosis and a fungating colon cancer, the hepatic flexure. The main key investigation results are low albumin, the CTP class, etc. The surgical risk score calculated by the Mayo method, rather high. So should the surgeon operate, and do I approve of TIPS? And when I was asked this question, my answer to the surgeon was, no, you should not operate. It's too dangerous, and I do not approve of TIPS. Well, the surgeon went ahead and operated, did not put in TIPS, and the patient actually did extremely well. So one has to be a little bit circumspect. Now, the best way, obviously, to predict the future is to look at the liver itself. And here, back in the Babylonian period, the time of Hammurabi, you see they had clay models of sheep liver, which they would use to compare with the liver they took out at the time of prediction. And this is a bronze Etruscan model from about 3000 BCE. And so I'm willing to understand, listen to any questions, and I'd be very pleased to send anybody a copy of this lecture and a copy of any of those articles if they simply send me their email address. And I thank you very much.
Thank you very much, Adrian, for this excellent and detailed review on this challenging topic for clinicians, particularly for hepatologists. Actually, because this is a state-of-the-art lecture, no question and answer session is scheduled. So,
I'm off the hook.
So thank you very much again for joining. Looking forward to meet you in Malaga really shortly after this pandemic is over. Thank you very much.
Yes, I hope you're doing something about it. But if anybody likes a copy of any of the lecture or the slides, please get in touch with me. I'm really a lot of data, and I really like to share it with people.
Thank you. Thank you very much. Thank you very much, Adrian, for this excellent and detailed review on this challenging topic for clinicians, particularly for hepatologists. Actually, because this is a state-of-the-art lecture, no question and answer session is scheduled. So,
I'm off the hook.
So, thank you very much again for joining. Looking forward to meet you in Malaga really shortly after this pandemic is over. Thank you very much.
Yes, I hope you're doing something about it. But if anybody likes a copy of any of the lecture or the slides, please please get in touch with me. I'm really, a lot of data, and I really like to share it with you.
Thank you. Thank you very much. Bueno, pues hemos llegado al final de esta jornada contra viento y marea que se ha transcurrido, yo creo, ha sido un desafío también hacerla mixta, presencial y online, y bueno, tenemos que agradecer pues el trabajo tan intenso que ha hecho Andrés González para que hayan podido hacer todas las presentaciones con mínimos problemas técnicos. Yo quería agradeceros bueno, a todos los que estáis aquí, por supuesto a los ponentes que han venido, a los moderadores, a los que sin poder venir, porque realmente no es que no hayan querido, que no han podido, pues se han prestado a dar sus charlas de forma virtual, y también, por supuesto, a la industria farmacéutica por apoyar este evento y hacerlo de forma entusiasta para hacerlo posible un año más. El próximo año serán las 20 jornadas, sí, 20ª jornadas de avances en hepatología, 20 años ya, y bueno, pues, espero que la podamos hacer totalmente presente. Muchas gracias y hasta el año próximo. Gracias.